It's a pleasure to be back in India. Here's the last time I was here at your meeting in Hyderabad. There's Melinda and I operating on a young patient who I think did very well. And it's a treat for me to be back. Everyone's welcome to visit us at Jules Stein. This July we have in June we have our annual blepharoplasty course, which goes over these techniques in detail. I'm going to focus on 4 areas that I think are very fruitful for the hyaluronic acid gel fillers in the periorbital area. The first is the concept of tight scars and dermal tissue expansion. Here's a patient with a tough problem, congenital ichthyosis. And these are very difficult surgeries. I'm sorry, it says the codec is unavailable, even though it worked in the... Oh, it's going. I'm sorry. Okay. But these are very difficult cases surgically. So what we did in that case is we filled in the dermis to try to act as a tissue expander for the tight skin. And with repeated injections, I find that these patients can, here you see we've eliminated the lag of thalamus. The skin stretches over time. Another example is in a multi-operated scarred eyelid. Those of you who have referral practices probably see patients like this. This is impossible surgically. This eyelid has turned into cement. But with multiple injections within the scar tissue, we can gradually stretch like a tissue expander and at the same time provide the volume support to help the eyelid to close. This is a patient with severe eyelid scarring after blepharoplasty mid-facelift. She had seen many plastic surgeons who all suggested surgically. I don't believe this is a surgical problem. I think it's a biological scar. My results are much better with repeated layers, small amounts of hyaluronic acid gel to stretch the scar, along with some 5-fluorouracil for some biologic treatment of the tight tissue, with a much better improvement, I suggest, than could have been obtained with surgery. We've used this in congenital eyelid malpositions. For example, this patient with congenital eyelid retraction ectropion, instead of taking the patient to surgery, in the intensive care unit, under minimal anesthesia, we inject the skin of the eyelid to achieve that stretching effect, here after 1 layer and here after 2 layers, showing the improvement in closure without having to go to the operating room. And another patient with a congenital coloboma of the lower eyelid, treated instead of surgery, this small infant, just with topical anesthesia injections to lengthen the eyelid and allow it to close. And Melinda, you were asking me, I think that this does provide some permanent effect by chronically stretching the tissues. The next area that I'd like to touch on is lower eyelid retraction and the role of volume. For years, when I thought about eyelid retraction, I focused on tightening of the retractors, shortening. But what I think happens now is, instead of just having middle lamellar shortening, I think there's a volume collapse, either an involutional or post-surgical retraction. And so I focus much more on adding volume to the eyelid instead of adding a quote, spacer. I don't believe that concept of a spacer as much as I used to. Here's a patient 1 week after surgery referred in with a tight eyelid and chemosis. So here I'm using the hyaluronic acid gel in the office to allow the eyelid to close to protect from the chemosis. And then here's that patient several months later. I believe that we helped this patient. I think without treatment, this eyelid would have been stented down with a permanent retraction. But I think by early on, providing that volume support like a stent, we were able to rescue the situation, break the cycle of chemosis, and I propose to you create some permanent improvement in the eyelid position. Here's a patient with lower eyelid retraction and hollowing after blepharoplasty. Here she was after surgical treatment with some improvement, but not as much as I wanted. So then we went and added hyaluronic acid gel filling, and you can see how much more improvement I was able to get, both in the function of the eyelid and also the appearance of the volume collapse. Another patient post-blepharoplasty eyelid retraction difficult surgical problem, but here she is immediately after Restylane filling, and this is a ultrasound, high-resolution picture that is demonstrating before up above and afterwards down below the effect of the Restylane filling. And I think that you can see the columns of Restylane in the inferior orbit along the plane of the eyelid retractor. You see the hypolucent, or the black spots, that demonstrate that Restylane all through the eyelid retractor plane that's supporting the eyelid like a column or a strut, replacing the volume that was lost in the blepharoplasty surgery. The same principles can be utilized in upper eyelid retraction, where we inject in the plane of the levator aponeurosis. I like to use a conjunctival approach with 1 or 2 injection sites, perhaps a half a cc, 0.5 cc's is a good starting treatment. Here's a Graves patient with mild chronic retraction. 12 months after filling in the right upper eyelid, you can see improvement in the retraction that was sustained. Here's a young patient in the acute phase of the disease, really too early for surgery because she's still unstable, but it's very nice to be able to offer in the office Restylane or hyaluronic acid filling of the levator plane to let the eyelid down, make her more comfortable, and maybe Malend, during that first year, teach the levator to have a little stretch. I don't know for sure, because in Graves patients they can get better on their own, but I've seen good long-term improvement in the retraction from 1 or 2 injections. Post-surgically in the upper eyelid can be also useful. We had some very nice talks about ptosis, and I noticed that all the presenters agreed that ptosis surgery can be unpredictable. Here's a patient of mine with an early overcorrection, with a potentially difficult situation. Of course, you can try to go back to the operating room, but that's very negative psychologically for the patient. And maybe, Ashcock, you're better than I am. I'm not so sure I can get it right the second time either. It's still unpredictable, right? A small amount of ptosis. So here, just in the office on that first post-operative visit, first of all, I'm sorry, here she is after massage, not much improvement. So then I went along in the top slide, placed hyaluronic acid gel in the levator plane. Now you can see she's improved. In fact, she's a little bit overcorrected, a little bit ptotic now. But then 1 month later, the eyelid's coming back. After 4 months, I think she has acceptable symmetry. And perhaps by stenting the levator in that early plane, there was some long-lasting improvement in the ptosis. If nothing else, it made her happier during that early post-operative phase where she was unhappy. Now, here's a patient referred in with retraction of the upper lid after blepharoplasty. Patient's very unhappy with the first surgeon, very unhappy that their eyelid feels terrible, not very excited to go back to the operating room. And again, psychologically, it's such a big deal to go back to surgery. So here she is after 1 treatment in the levator plane of the hyaluronic acid, letting the eyelid come down, protecting the cornea, and rescuing a difficult situation. Finally, the upper eyelid filling can be used as a gold weight or a levator, an eyelid weight for facial palsy. Here's a patient with lag of thalamus related to facial nerve weakness on the right side. Here she is immediately after placement of the gel. Now you can see it does make a little bit of a bump in the eyelid. The patients have to accept that, but she was willing to accept that because of the improvement in closure, which in this case was sustained for 9 months. Here you can see 9 months later she still has improvement in the lag of thalamus. Another patient, the gel was placed a little bit higher here, so it's not quite as obviously cosmetically. But you can see before and after the injection the improvement in eyelid closure by adding the weight to the eyelid. So that's particularly useful for a potentially temporary case of facial palsy. Finally, I'll amplify the concept of filling the periorbital hollows that was just discussed so beautifully. When we really think about how the face ages, it ages by losing volume. Deflation is a big part of aging. We lose volume in the superior orbit, we lose it in the inferior orbit, and I don't like the word tear trough deformity. I propose we think of an orbital rim deformity that goes across the entire orbit. I'm not even convinced we gain that much fat in the eyelid. I think that the loss of fat in the periorbital area is an overwhelming, important problem. And so when I think about evaluating the patient with the aging face, in the past, this is a patient who would have been told, well, you just need a blepharoplasty because you have a bump there. You can see the fat is pooching out of your eyelid. But when I look, I see a hollow. I see a superior and inferior orbital rim hollow, zygomatic, and what I call a septal confluence hollow. And I think that the treatment for many of these aging problems is with periorbital filler injections, and was already shown this is done with a very gentle, delicate technique, sometimes just 0.3 cc's per side in a deep plane below the orbicularis with a carefully sculpted shape, multiple fine injections required to create a careful three-dimensional shape. This is not an area for beginners because it's a very complicated contour, and the injections have to be artistic and they have to be conservative. But the improvement that we can get in those hollows I find very impressive, even better than what I can usually obtain with surgery. Again, this patient might have been thought to be a candidate for lower blepharoplasty, but she does much better with periorbital fillers. This young man gets a much better result from the fillers than I think he would have gotten with any type of surgery. This is a patient who was adamant about not having surgery, and you can see with the completely non-surgical approach we've been able, by filling these periorbital hollows, to achieve a significant improvement in the contours, which lasted 18 months before he was ready for a second layer. And just a couple other examples of that nice effect we can get from periorbital filling, which has changed my practice at UCLA and has created very happy patients. We can also get a cheek lifting effect by filling the cheek. And one thing I want to point out here is the improvement in the nasolabial fold in the brow area that we get by essentially lifting the entire face by replacing the volume in the mid-face. How long does it last? Well, in the orbit, I've been seeing results as long as 3 years. And this is a patient who came in recently with 5-year follow-up, still with a good improvement, although I think she has a little bit of edema that you can see over the orbital rim. And one disadvantage of the hyaluronic acid gel fillers is they can create a little bit of edema. The superior sulcus is also an important area. Here's a patient in youth, and at age 40, you can see that her aging was really a loss of volume in the superior sulcus. And so here she is in the office immediately after filling that superior sulcus, and you can see the improvement or the rejuvenation that we can get without surgery, but with filling alone. I think that much, and I'll talk about this afternoon, much of what we used to do in the upper eyelid, at least what I used to do with blepharoplasty, I now see as a volume loss, and I'm much more likely to treat patients with hyaluronic acid gel. Another Asian patient showing that loss of volume along the orbital rim, and in a Caucasian patient that often presents as what appears to be extra skin, but it's really just a volume problem, better treated with fillers than with surgery. Same thing here. No surgery was done here, just filling with the eyebrow fat pad above the orbit. And in the severe hollow orbit patient, I'll not only fill the eyebrow fat pad above and the superior sulcus, but also actually inject behind the eye to allow the eye itself to come forward. Now that's very much off-label, but there's been more and more experience filling the orbit itself with the Restylane. And the last thing I'll mention briefly is this idea of the Charlie Brown hollow. This is my new name for this lateral orbital hollow, particularly noticeable in patients with thin skin, as you can see here with the ultrasound. Now, sometimes surgery in the lateral fat pad can help that. This patient was just treated with surgery to debulk the lateral pad. But more often nowadays, I'll try to fill that lateral orbital hollow. So we're filling right under the orbicularis above the periosteum in the lateral orbit. And we can achieve very nice improvement. This patient was treated not with surgery, but with filling alone. But it's a difficult area. Here's a patient showing some improvement, but you can see a little bit of the filler. This is, I think, the most difficult area for filling, but it's a potentially fruitful area. So to summarize, we talked about several applications for the hyaluronic acid gels. The tight scars, the concept of a tissue expander, lower eyelid retraction, upper eyelid retraction in the levator plane or as a gold weight, and finally we talked about some of the concepts of filling the periorbital hollows in the lower orbit, upper orbit, and the lateral orbit. Sorry, Professor, to go 12 seconds over, but I appreciate your attention.
Thank you very much, Dr. Goldberg.